the incidence of Kaposi sarcoma in general and with invasive tracheobronchial involvement has become increasingly rare. This case exemplifies the importance of providers including pulmonary Kaposi sarcoma in their differential when evaluating a patient with known cutaneous Kaposi and HIV/AIDS presenting with new onset respiratory distress and hemoptysis. This case is about a 34-year-old male with a past medical history of HIV/AIDS, cutaneous Kaposi sarcoma, Charcot-Marie tooth disease, and depression, who presented with shortness of air, new onset hemoptysis, and increased secretions from his tracheostomy. He had a tracheostomy placed a few months prior to admission due to laryngeal edema and tracheitis caused by radiation therapy of an anterior neck Kaposi sarcoma mass. He was not taking his antiretroviral therapy, and most recent CD4 count prior to admission was 83. Infectious workup on admission was unrevealing, with a chest x-ray showing a right lower lobe pneumonia for which he received empiric antibiotics. CT chest noted narrowing of the trachea, diffuse thickening of the large airways, mediastinal lymphadenopathy, and ground glass opacities. He was started on antiretroviral therapy and PCP prophylaxis. Multiple tracheoscopies around this time showed tracheitis not improving with treatment. He developed progressive dyspnea and hypoxemia and subsequently had PEA arrest, for which he received ACLS and was placed on mechanical ventilation. Bronchoscopy performed soon after revealed a large semi-organized clot completely occluding the right mainstem bronchus and the entire visible trachea, carina, and bilateral mainstem bronchi involved, with extensive and extremely friable polypoid lesions with some extending into the lobar airways. Endobronchial biopsies taken during the procedure revealed HHV-8 positive atypical cells consistent with Kaposi sarcoma. He was unable to start active chemotherapy given his critical illness and declining condition, so he underwent an additional therapeutic bronchoscopy with plans for ablation and debulking of the lesions to control his periodic hemoptysis and improve central airway patency. During the procedure, clots were cleared. However, due to the extensive nature of the lesions, intervention was deemed futile and aborted. Soon after, he transitioned to comfort care and passed naturally. Kaposi sarcoma is an increasingly rare complication of HIV/AIDS, and with the evolution of antiretroviral therapy, its incidence is decreasing. This case illustrates that pulmonary involvement should be considered in individuals with known cutaneous Kaposi sarcoma and HIV/AIDS presenting with respiratory distress and hemoptysis. Median survival of patients with pulmonary Kaposi have increased significantly with the combination of antiretroviral therapy and chemotherapy. Additionally, endobronchial ablation therapies may help control bleeding and airway patency. As this case demonstrates, severe invasive disease may preclude effective use of these therapies. Thus, despite the decreasing incidence of Kaposi sarcoma, early intervention is critical in management.